That video, you can just barely glimpse it. I think I had to look at it a couple times. Just in the replay, it was from a distance, and I think there's better replays out there now, but that is painful. Okay.
Somebody said something, and I thought it was actually kind of funny. Somebody said, "How are you going to talk crap about Oklahoma in that shirt?" He said that. I'm like, "That's pretty freaking."
What shirt was I wearing?
I don't remember. It didn't stand out as anything like. It wasn't like
Hey guys. Where am I, Joey?
your head's out of the frame.
It's like, all right, okay, we're gonna do this right now. All right, okay. So, first of all, welcome. Come on. It's this friendly competition. Oklahoma's a great team. I was just saying what I was saying. I know you guys didn't like the comment, but it's kind of like if you were to make fun of the Leafs or the Oilers. Go ahead. It's all good. It's about the game. You know, friendly competition is good. Tell me how much you love your team. Hey, it's all good. Anyway, it was slightly different area. I had to fit it in with some of my clinic time to get this video in for you. So we're shooting live. All right, so Fred Warner. Which side is the video?
Which side do you want it on?
I want it on this side.
There you go.
Because my finger's over there.
There you go.
Okay.
Your fingers also. You got a lot of fingers.
Joey. All right. That video, you can just barely glimpse it. I think I had to look at it a couple times. Just in the replay, it was from a distance, and I think there's better replays out there now, but that is painful. I've seen it happen. I've seen it show up in the ER. I've seen it show up splinted from the ambulance. You arrive and it's still, you know, these type of injuries can be very unstable. You saw the providers on the field just kind of lining it up. I don't know if they reduced it on field. More than likely it was reduced on field and then splinted, and you saw him being carted off. That was Dr. Tim McAdams, who is in the cart with him. Fred Warner, why am I banging the table? So, not a great injury. We don't know all the details yet. We know that it was a fracture dislocation. Now, broken, fracture, okay, it's essentially the same thing. Some people think there's a difference. A fracture is, it's just a hairline break. A break is a complete break. Well, the words mean the same thing. Fracture we use in more medical terminology. Break is a more general terminology, and we use it back and forth, like a broken hip or fractured hip. It's the same thing. Broken leg, fractured leg, okay? So the question becomes, what kind of break, what kind of fracture, what kind of fracture dislocation? So unfortunately, I don't have my models here. Just for time's sake, I'm fitting this video into clinic time, but basically between clinic time, don't worry, no patients are sitting in the waiting room waiting for me. Don't worry. And again, educational video. I'm not the treating surgeon or the physician for Fred Warner. I am a surgeon. I take care of all joints, and I am an operating surgeon and physician, but I'm not the one taking care of Fred Warner. So this is primarily as education for you. Even the Oklahoma fans. Oh! Sorry, Oklahoma. You guys are great. I almost took a job in Oklahoma. Just didn't know anyone out there, but it's okay. It's okay. That was a long time ago. So regardless, we're talking about the fracture dislocation and are you still impressed with my sound effects? Yeah, I think so. And what happens with a fracture dislocation? Well, the most important is to line up the joint first. So no matter what, You can have a break and some displacement, but the most important thing you can do is line up the joint. So you have good symmetry, which means that the joint spaces line up. So in the ankle, think of it like a U-shaped horseshoe with a block in there, and the ankle lines up. You have a malleoli on both sides, which are part of the ankle bones. And essentially, if that lines up on multiple views, typically on at least 2 to 3 views, then you have reasonable alignment. And the reason for that is, yep, you got it. I heard you out there. What did you say? Reduce the risk of cartilage injury and post-traumatic arthropathy or cartilage degeneration, impact, or anything. Now, when you have a fracture, is it in the joint, outside the joint? If it involves cartilage or doesn't involve cartilage? There are so many facets in fractures. Now, as far as we know, it wasn't an open fracture. Open fracture is when any part of the break or the dislocation communicates with outside the skin. So you could have a little abrasion, but if it doesn't penetrate and go right into the joint, then it's not an open fracture. Open fracture, higher risk of infection, higher complication rate, longer treatment to make sure it's not infected, and then the healing. All of those factors come into play because you have exposed air from outside, exposing the interior space, which is typically sterile. Okay? So, got it? Got it. Good. I know you got it. I know you guys. You guys are smart. You know, I've been doing this for a while, and I know based on all the comments, even Oklahoma, all is good. I love you guys. Don't worry. So, you can trash the Leafs and the Oilers if you want. They're my teams. I love them. I love hockey. I don't have just one team. Do I like the Vegas Golden Knights? I don't want them to win, but I'm a Mitch Marner fan. And do I wish the Golden Knights get beat by the Leafs and the Oilers or even Ottawa or the Jets or the Colorado? Yes. I love Nathan McKinnon. I like how the Avalanche play. Do I enjoy how Tampa Bay plays? Yeah. But do I want them to win? No. So it's all good, guys. It's all good. You can trash my hockey teams and football teams, go Niners, but it's all good. It's all in good fun. Love you guys. All right. So back to Fred Warner. What do you think? What are your questions, Joey? So we're going to bring in our camera guy. He doesn't want to be on camera. He just wants to be the peanut gallery in the background. So what's your question, Joey?
So when it's dislocated like that, does it tear all the tendons in the ankle? Because it was sideways.
So this is a great question. It shows how little Joey knows. I'm just kidding, Joey. So when you have a dislocation, the joint capsule is disrupted. Okay, so the joint basically, when it's lined up, so you have your ankle mortise, okay, you got your malleoli on both sides, you got your ankle mortise, sorry I don't have my model, and then it's the capsule and the ligaments around there that often get disrupted. So if it goes out a certain way to the inside, then you disrupt your lateral ligaments, so you can also disrupt your anterior and medial, and then if it goes to the outside, then you can disrupt your inner ligaments, the deltoid ligaments, and obviously it's three-dimensional. You know, you could have mostly anterior medial, you could have posterolateral, anterolateral. There's a lot of different ways the ankle could go: posterior, anterior, medial, lateral, or any one around. And then it could also take a part of the bone with you. And so if it takes a bone and fractures and breaks it, you could have it either a simple fracture, like an uncomminuted, clean break, like we call it, oftentimes people call it, or a comminuted fracture. And a comminuted fracture means it's in multiple fragments. Now, that raises an issue within the joint. If it's comminuted and you have cartilage fragments within the joint, then when you do the surgery, you actually have to go in there and make sure nothing's trapped. There's no loose fragments, there's no loose bodies. And the minuscule, tiny microscope, not always microscopic, but 1-2 millimeter or less fragments, sometimes you can't do anything about them. You have to take them out. If they're large fragments, you can place them. You put little small tiny screws or K-wires or cannulated screws or special types of devices and implants that are absorbable so that they can actually hold the cartilage in place. And that's where the foot and ankle specialists reigns supreme. Getting all of those parts back together. How much of the fragment? Is there a fragment? Is there an avulsion of bone? Is there a break in the bone? Does it involve the tibia or the fibula? What part of that is involved? Does it go all the way up to the top and also take out? Is my hand in the frame? No. Is it in the frame now?
Yes.
Is my head in the frame?
Yes, that'd be awesome. We're like 15 minutes in, you're like, you're not in the frame.
Am I even in the frame? I'm being forced to sit. I'm used to my space. Like, I can walk, I can talk, and I can, you guys can make fun of me all the time. Seriously, dude. Like, I love the banter. Feel free to make fun of me. It's all good. My teams, me, it's all good. Love it all. Love it all. All right. So, cartilage is the most important part of a joint. If you damage the cartilage, that's what leads to post-traumatic arthritis. Now, initially, there's two terms, arthropathy and arthritis. Arthropathy is when you have changes within the joint space and evidence of cartilage degeneration, and that shows it's developing into irregular joint space and cartilage damage. Arthritis is pain associated with joint problems. So you can have arthropathy without pain, and you often see that in who? Marathon, long distance runners, and even sprinters. Like, the best example is, I get referrals many times where, oh, my primary care doc took an x-ray of my knee, but I'm fine. I can run 20 miles a day. I don't have any issues, but he took an x-ray of my knee and he got all worried because of the arthritis. Well, in that case, if you're running, if you're active, if you're healthy, and you've got good motion, even if you've got changes in your cartilage and your bone and your joint space is narrowed, there's no reason for treatment. If you have symptoms and problems and function, or break something or damage something, and you have pain that's limiting you in work, rest, play, home, then that needs treatment and intervention. And some of the best patients are farmers. My goodness, they will show up with joints that are almost destroyed, but they get their work done. And they say, oh, I'm fine. I don't need a joint. I don't need surgery. So when they show up, their problems are severe because they work through the pain. It's incredible, some of the pathology that you'll see in farmers. Best patients ever. Now, going back to the athletes, they're challenging patients because they want to get back on the field. They will follow your protocol to the limit about the healing, but when can I return to the game? When can I play, doc? Those are the questions you will always get. So they're very motivated. They want to get back. And so that's always a bit of a challenge. I'm not going to say 6 or 7, okay? I'm not going to say it. Don't even try me to say 6 or 7. Stop. So, with Fred Warner, he's going to be an athlete who wants to return back to the game. There's going to be pressure from everyone, from himself in particular. The fans want him back. The coach wants him back. The team wants him back. His players want him back. But most important, he wants himself back. And so good motivation, but there's always a balance. You have to sort of balance the healing. So there's going to be recovery from, we don't know what surgery he's getting. We don't know whether he's had surgery yet or not. And we don't know more details about his fracture or dislocation at this point. So,
if he hasn't had surgery yet, is that...
It's okay. It doesn't...
But there's not like a reason for why you would have surgery immediately versus surgery a little bit later?
Yeah, so a good question is, would it have mattered? Like, if he's going to have surgery, why didn't he have it right away? Well, sometimes if it's a severe fracture dislocations, what are you most at risk of? Okay, let's assume no nerve or vessel injury. That's a separate conversation. But what are you most at risk of? I heard it out there. Fracture blisters, exactly. So when you blow it out like that, even if it's reduced right away and you ice it and you splint it, it'll blow up and you'll have fracture blisters. What are fracture blisters? Good question. So you know how when you burn, You get blisters. Well, in a fracture situation, you get so much swelling so quickly that the fluid seeps through the layers of the tissue and forms blisters. That is a higher increased risk of infection if you cut through fracture blisters. So either you operate right away or you let the swelling subside, settle down, get the imaging, get the test, realign it. Sometimes you may just do a closed reduction in the OR. So that means you line it up so the joint is perfect. You may put a fixator on it, or you may put a cast on it, and then you elevate, ice, let the swelling come down, and sometimes you wait, 2-3 weeks, maybe less, maybe longer, to let the swelling subside. As long as the fragments and the joint are aligned, you can give it time. Now, ideally with fractures, especially in young people, you want to fix them within 10 to 14 days because they heal quick. Older patients don't heal as fast sometimes, but the main thing is don't put a 6 or 7 graphic on there, please. We got to change that. It's hilarious, but anyway. So the challenge, of course, is the healing potential and the healing capacity. And so just because he didn't have surgery right away doesn't mean there's anything wrong. It just means that's a decision by the surgeon and his treating physicians and team and his surgical team about what the ideal timing for surgery is. And it's not always right away. If after he got off the field, into the ER, got his CT, x-rays, and whatever imaging they wanted, and an MRI, and they realized this is swelling already so much, he's got fracture blisters, let's wait. The risk of infection by cutting through or near fracture blisters is very high, because what else can happen? I heard it. Compartment syndrome. Now, with ankles, the risk of a compartment syndrome is less, but you can have it if you swell up right away, because then when you cut through the skin, depending on the extent of the fracture or dislocation, sometimes you can't close the skin. So if there's so much swelling and it's tight and you can't close the skin, with or without compartment syndrome, you may have to do fasciotomies, a whole other topic. But even without that, without compartment syndrome, if you can't close the skin, then you have to just approximate it, dress it, and then come back and then do a secondary closure. And so that puts you at risk for an infection and other complications. Other things that he's going to be at risk for: blood clots, assuming no nerve or vessel injury. We don't know all the details, but you're not going to be putting full weight initially. And so typically everyone has different protocols. Everyone does. Some people use heparin, some people use Lovenox. There's all sorts of oral anticoagulants. For healthy patients that are walking, you don't have to use a blood thinner. Sometimes you do. And oftentimes the best data right now is that people often switch to an aspirin, baby aspirin, BID, depending on the risk level. And all of that is the decision between the physician, the evidence out there for that particular injury, and the discussion with the patient. It's always a risk-benefit analysis. And that's the important thing.
Cartilage and ligament, is it kind of the same healing process? Do they totally different?
Yeah.
This is cartilage.
More than likely. So a good question. What's the difference in healing between cartilage and ligament and tendon and bone and all of that? Well, bone heals the best, okay? Bone, osteoblasts, that type of healing is really good. So sometimes it's better to get a fracture than a sprain, because with collagen, there's always a challenge between getting stiffness. Now, it's a mild sprain, you heal, you recover, you go faster, but it's a complete rupture, then ACL is a great example. The ligament doesn't heal. You have to do a reconstruction. Whereas if you get a tibial fracture, it's worse, but depending on whether you need surgery, the bone does heal. So in the greater principle of things, bone heals well. Now, if you have a ligament injury, sometimes you repair the ligament, you reinforce the ligament, you reconstruct the ligament, different types of collagen in the different tissues. That's a whole basic science concept. We can probably do another segment one day on the different types of collagen, the types of healing, and when you get fibrous collagen, a certain type of collagen forming first that gets converted. And then we've talked about this before, Sharpie's fibers and Wolff's Law. When you start healing, then you want to start stressing it at a certain point. We typically talk that 6 to 8 weeks. Do we want to start stressing it? Because then the collagen fibrils line up better and they create that elasticity. And it's that type of, it's almost like you're telling and reminding the body of how the collagen fibers need to line up. Now, is it linear? No. Is it three-dimensional? Yes. Now, ligaments, bone, cartilage is different. The blood supply to the inner cartilage is very different. Most of the nutrients for the cartilage comes from the synovial fluid. That's the joint fluid. So that means that the blood supply going in isn't as good. So that's why when you get cartilage injury, if it's a large fragment with bone attached, it is better healing than if it's a flake of cartilage gone off. Now, sometimes you may try and repair and heal the osteochondral fragments, but some of the small fragments, there's not a lot you can do. You want to prevent that from being a loose body and grainy sand within the joint. So you have to flush it out and make sure there's no fragments within the bone. So there can be some loss of cartilage if you have a comminuted osteochondral or cartilage impact injury within the joint. And then, and we'll do a whole segment. I think it's worth going in because some of you want to know this. This is all about education, the nutrients and the supply and the blood supply of the cartilage. Even the meniscus, for example, which is a type of cartilage, different type of cartilage. Hoop stresses, very different, separate from the cartilage on the end of the bone, which is more like the gristle on the end of chicken bones. Different type of cartilage, different type of collagen as well. And then you get ligaments and tendon. Again, tendon, they get their blood supply from the peritoneum, the supplying tissue, as well as the ligament is from supplying tissue and vessels that cross that area. So ligaments, if you have a tendon disruption, the blood supply is very different versus a ligament injury where the blood supply may be a little greater versus cartilage where the blood supply is diminutive because it's right at the end of where the blood supply goes, so you're relying on the synovial fluid. So there's a host of different reasons and different tissues that are involved, especially in a fracture dislocation. Line up the joint to reduce the stress on the cartilage. For example, here's a good example. Say you have the joint, or I'll make it even simpler. You've got the joint like this. Imagine if you have a joint sitting like this. Point contact stress, right? You're putting all the pressure in one area as opposed to distributed forces. The distributed forces equalize. It's no different than when you get flat spotting on tires or when you get a change in tire pressure. For example, it's freezing outside. It dropped below 70 degrees. You're going to make some comments, I know. So it's freezing outside because it dropped below 70 degrees. However, the air pressure is such that all of a sudden you're going to get low pressure. So there's people out there that haven't equalized their air pressure, and so it's flatter, more surface area. So what does that mean? Square pounds per force per square inch, right? I may not have said that correctly, but it's the pounds per square inch. And that means that your tire becomes wider, flatter, and so your risk of sliding is higher. And if you don't have good tread, that also makes a difference. Now in cartilage, the tread pattern, having tread is not good. If you have disruption in your cartilage alignment, that creates essentially kind of like where you get little potholes in the road. It's no longer smooth. So if you don't have smooth gliding, that becomes a factor as well. So aside from lining up the bones, fixing the bones, we don't know about his surgery or what he had yet. It becomes about lining up the cartilage, making sure it's symmetric, equalized joint space, multiple views, sometimes a CT scan afterwards will help. And many of you ask, why get a CT when you have an MRI? Well, you're looking at different things. And that's another, we can go into that another day. The difference between the different imaging that we do and how that we use and how that affects our decision making. Because the more you know, the more informed decisions that you can make. So why don't we, again, let's make an assumption. We don't know his exact injury. Let's assume a straightforward fracture dislocation. A clean break, let's just say it's his medial malleolus, which is a fragment of bone off the inside of his ankle that breaks cleanly, that you can place screws in, and it just dislocates and comes back in. No cartilage fragments, no damaged cartilage in the sense that there's no osteochondral injury. Okay, so the best case scenario with a fracture dislocation, you line it up, you stabilize the medial malleolus with screws, and sometimes you need a plate depending on the angle. And here's a great example. If it's oblique, it can shear off. If it's lined up perpendicular, then you can just put screws across. You may or may not need a buttress plate to prevent it from shearing off, just based on the biomechanics and the physics of the fracture. Now, bone in the ankle, 6 to 8 weeks, maybe 2 months, 3 months if there's delay. There's other factors. I'm not saying that these are factors in Warner's case, but we're talking about, is he taking nicotine or any other, maybe he has other medications. Is there anything that could delay fracture healing? Does he start walking on it before he's allowed to? Those can affect fracture healing. So assuming 6 to 8 weeks for the bone to heal, let's assume he has a ligament stretch without a disruption of the deltoid or the lateral ligaments. Because typically when you have a break on one side, the ligaments will stay together, the fracture breaks. The energy goes through the fracture. So the other side may have ligament disruption. So he may or may not need ligament repair on one side versus the other, depending. We're talking about a medial malleolus, so he may have ligament disruption on the other side or not. And when that happens, the tendons could fall out of alignment or in alignment. You could affect the peritoneum, but typically the tendons don't rupture or tear or disrupt. They can. The peroneal brevis is well known for having a split peroneal brevis. You can have the peroneus longus affected. The peritoneum, the sheath, can be affected. There's lots of different things that can happen, but assuming the best case scenario, a clean break of the, let's just say medial malleolus, line it up, screws, heal. He's going to go through rehab. He's going to start strengthening. And, this could be anywhere from 4 to 6 months or longer, depending on his recovery. Now, athlete, good rehab, treatment, maybe they even do some regenerative technology. Maybe they even put them on some type of a growth hormone, because a lot of times there are various analogs that can be used for bone healing. There's multiple of them that can be used off-label. Some of them are being used in Europe. Maybe he flies to Europe, gets some treatment there. There's differences in treatment between the European regulatory body and outside U.S. regulatory bodies and the FDA. So there can be different treatments that he can get that may not be available to us, that even I couldn't afford, that he would afford. And so there's different options and treatments for it. But fracture dislocation, as early as 3 months, it's pushing it. Because even if he heals, getting the strength, the balance, the proprioception, and the confidence to get back on the field and push hard is always a challenge. Assuming no ligament tear, just single bone fracture, and no cartilage injury. And here's the thing. Even when you pop the joint out and back in, the cartilage can impact. You get those bone bruises. You can also shear some cartilage. So even though you don't see macroscopically or visually when you're looking at the joint, there's no cartilage damage. You can have long-term consequences just from that impact physiologically that can run into problems later. So, but I'm hoping he's going to be back. Again, this is educational. We don't know all the details. When we do, we'll give you updates, but that's what I got for now.